we've got James Thompson, who is also a postdoc at the Turing Institute. He's going to tell us a bit about a COVID model he developed for Luxembourg before joining the sharing. Over to you, James.
That's right, thank you. So I hope everyone can see the slides. So firstly, I'd just like to thank the organisers for the invitation. It's really nice to have the opportunity to speak. So indeed, I've been at the Alan Turing Institute for a couple of months. Before that, I was based at the University of Luxembourg. So I was going to share with you today some work that I was doing mainly over the past year in Luxembourg, and that was joint work with Stephen Bottom and Nikolai Kasperschak. Stephen is a software engineer, so he was contributing to the project mainly from that angle. And the project, which started early last year, had the objective of trying to build a computational model of COVID-19 for Luxembourg, and to use that model to investigate the impact of interventions such as the lockdown, curfews, contact tracing, testing, vaccination, and so on. So what I'm going to do today is just give a very brief overview of the model, and then a brief overview of some of the results that we obtained using the model. And then at the end, I'll give you some links to the code and to the preprint so that you can see the details in case you're interested. I should say that I apologize for missing the second session this morning. I think the model that I'm going to present has some similarities to the models that we discussed this morning. But I was getting the first dose of my vaccine, actually. So that was kind of my priority. And then coincidentally, I'm now talking about vaccination. So that's definitely the theme of my day, is vaccination. So anyway, the project was called ABM Lux. And as I said, the objective was to build a computational model of COVID-19. So we built an agent-based model. And so in an agent-based model, for those who are not aware, the idea is to simulate individuals, or agents representing individuals, to simulate their behavior and their interactions. And then in this context, we observe the dynamics of the epidemic as emerging as a result of that system of interactions. So this is somehow the sort of bottom-up approach to modeling an epidemic, as opposed to the top-down approach, which would be to postulate a set of equations that you think describe the dynamics. And so, as was probably discussed in some of the other talks, one of the advantages of the agent-based approach is that you can build in a lot of heterogeneity so as to get a relatively realistic model. So such models indeed have been used quite extensively to study COVID-19. And as I said, I think our model has some similarities with some of the ones that were discussed earlier. So we focused on Luxembourg, but from the very beginning, we designed the model in such a way that it's quite flexible and can be fairly easily adapted to other regions. So in particular, now that I'm based at the Turing Institute, I'm in the process of adapting this model for the UK and sort of refactoring it and improving it in various ways. But in this talk, I'm just going to focus on Luxembourg. So first of all, I'll just give you a kind of an overview of the model. So in some sense, there are 4 layers. There are the agents, which, as I said, represent individuals, or represent people, locations, the disease, and then a collection of interventions. So the way the model works is that agents perform activities. So throughout each day, each agent performs a sequence of activities. So that could be activities at home, like cooking and sleeping and so on. It could be going to work, it could be going to school, it could be doing sport or visiting a zoo, or all kinds of different things. And we configure those daily and weekly routines using time use data, which I'll say a little bit more about in a moment. Having chosen an activity, agents then choose a location at which to perform that activity. And so then we use mobility data that was collected in Luxembourg, which sort of tells you typically how far people travel for various reasons. So when they're going to school or when they're going to work, etc. So putting that together, our agents are then going to move around a landscape of locations stochastically and potentially interacting with one another if they're in the same location at the same time. So before I talk a little bit more about the activities, I'll just talk about the locations. So this slide sort of illustrates the spatial component of the model. So on the left is population density in Luxembourg, represented as a heat map. So this blob here, for example, is Luxembourg City. That's the capital. The University of Luxembourg is down near this little blob here, and then all the rest of it is obviously little towns and villages. And then on the right, I'm plotting a sample of locations of different types, colored according to type. So there are houses, care homes, primary, secondary schools, restaurants, shops, zoos, gyms, etc. And the spatial coordinates of these locations are obtained simply by sampling the population density, which is, a bit of a simplification versus what we've seen in some of the other talks. But it's quite simple and it's sort of transparent and easily scalable. So the number of houses, the number of shops, the number of restaurants that we place into our model determined using data that we collected from a range of different sources, mainly OpenStreetMaps, but also StatEc, which is the National Statistics Agency of Luxembourg, and also the Ministry of Public Transport in Luxembourg. So we were sort of working with the COVID-19 task force in Luxembourg last year, and so therefore we were able to get our hands on a certain amount of data that otherwise might have been a little bit tricky. So more on that in a second. So that's the spatial side of it, that's the map. So then we have agents performing activities and moving between the locations. So this is a visualization of the time use data. So this was collected in Luxembourg in 2014. It's part of the harmonized European time use surveys. So basically what I've got across the bottom is a week. This is going from Saturday to Monday to Friday, sorry, Sunday to Monday to Friday to Saturday. And then on the y-axis, I've got population. So this is representing how many people are performing each of these colored activities at each time of the week. And as I say, this is gathered from the time use data. So there were about 2,000, or a little over 2,000 respondents in the time use survey. And so each one was asked to record a diary of a weekday and a weekend day with a 10-minute time resolution. So then we get over 2,000 sort of behavioral types in the model, and I'm just visualizing here sort of the aggregate of all of this. So for example, where my cursor is sort of right now, so this is Monday night. Yeah, so everybody is at home. And then as we go into Tuesday, we get a little bit of morning rush hour. That's this green, which represents people using cars. Orange is people going to work. People take some time off work at lunchtime to go to restaurants. That's yellow. Children are at school during the week. That's gray. More people, or people spend more time outdoors at weekends, visiting family and friends than they do during the week, and so on. So putting that together, that's the sort of spatial and the temporal resolution of the model, and we tried to build it in such a way that it's quite detailed, the different routines. So then on top of that, we've got the disease model. So in some sense, that's quite a straightforward thing. We followed the popular compartmental framework, where we've also got asymptomatics and hospitalization and intensive care. And the path that an agent takes through this diagram after infection is age dependent. And we also have it so that the time that they spend in each state is also age dependent. And I think in most cases we have these gamma distributed. And most of the parameterization of this, not all, but most of it came from COVID-19 clinical monitoring data collected by the Luxembourg Health Ministry between February and about August of last year. So for reasons that I might have time to explain later, we were focusing on the that sort of initial period of the epidemic in Luxembourg. And then the way transmission works is relatively simple. So during each 10-minute interval, so it's during each tick of the simulation clock, and for each location, so within each house, within each school classroom, within each shop, restaurant, etc. In the absence of any interventions, each infected agent, who I'm representing here as red, we assume infects each susceptible agent that I'm representing in yellow with some certain probability. So in this diagram, perhaps this is a shop. This orange person is exposed, so they're infected but not infectious, and the green people are recovered, so they're assumed to be immune. So the total number of new infections is going to be binomially distributed on each, at the end of each tick. So one thing I'd like to point out is that these agents might, let's say it's a shop, these agents might be in the shop for different reasons. Yeah, so a couple of these people might be working in the shop in our model, whereas the others might be simply doing shopping at the shop. So some of these agents are coming and going, others are going to be there, you know, for most of the working day. So that's the disease and transmission model. And then on top of that, and this is where most of the development time went, we've got a selection of interventions. So we've got testing. So that includes mass random testing, which they did a lot of in Luxembourg. And it also includes people getting tested as a result of developing symptoms and having been referred to get a test by their doctor and so on. We've got contact tracing, quarantine, face masks, a curfew, location closures, so that, for example, school closures, closing down locations of certain types, full lockdown, where, you know, people are confined to home unless, I think in our model, unless they're in hospital or unless they're going to one of the shops that sells necessary essential items or something. And then also vaccination, which ultimately was kind of the focus of the whole project, right, was on looking at the impact of vaccination. So by implementing several of these interventions, we were able to recreate the sequence of events that took place in Luxembourg between about last February and sort of last July, August. And then using data on hospitalizations and deaths in Luxembourg over the same period, we were able to validate our model. So we designed the model in such a way that the number of unknown parameters was quite small. So the approach that we ultimately took to the validation there was to basically do a small grid search over a set of different parameters until we found the one that we felt sort of most closely fitted the historical data. So that then allowed us to construct a baseline scenario in which no interventions are active, so that we could then compare the effect of interventions against that baseline. Now, I'll just very briefly review some of the results that we obtained. So the first is perhaps not such a result, but it just concerns the baseline scenario specifically. So one thing we wanted to do was compare the output of our model to the output of an equivalent SCIR model, you know, a system of ODEs. So that's what this slide has to do with. So in the SEIR model that I've not obviously shown in these slides, there are three unknown parameters, three transmission rates between the four compartments. So two of those are given by the mean incubation and infectious periods. And so we can calculate those within our model so as to get those equivalent. And the remaining parameter in the SEIR model is determined by R0. So we wanted to find a value of R0 that produced a peak in the SEIR model at the same time as the epidemic was peaking in our agent-based model. And so in the end, it turned out that R0 for that should be set equal to about 2.45. So what I'm plotting here is the number of people exposed and infected in the two models. So in the agent-based model here, by infected, I mean like the union of all of the infected states I showed you before. And this jiggity-jagginess here, this is the weekly routines coming through. So this is Monday, Tuesday, Wednesday, Friday. More people are getting exposed on weekdays and so on. So anyway, the point is that although these two epidemics peak at the same time, because the ODE model makes assumptions about homogeneous mixing, it sort of wildly overestimates the total number of cases versus what you get with an agent-based model where there's much more heterogeneity. So we felt that our model was producing output that was maybe a bit more realistic than some of the other models. So now I've got just two more slides. I've talked a little bit too much already. So this concerns non-pharmaceutical interventions. So on the top, we were simulating the impact of a combined testing and contact tracing strategy. On the left, looking at total cases, and on the right, total deaths. So for simplicity, I've looked at three strategies, which I've just called low, medium, high. This refers to the intensity of testing and contact tracing taking place. And obviously, we quantified this in the details you can find in the preprint. In all of these scenarios, we were looking at a particular situation where these interventions start precisely 3 weeks into the epidemic. So that's just something I should be clear about. We were allowing the epidemic to sort of get going, and then 3 weeks in, we were hitting it with these interventions. So roughly speaking, we found that contact tracing and testing had a fairly mild, well, yeah, a reasonable impact on reducing cases, but not huge. And its impact on reducing deaths was actually not enormous. And I think that's for sort of two reasons. So first of all, we tried to take into account a bit of a lag that exists in the system. So we had some data collected in Luxembourg to do with the time between somebody developing symptoms and the time in which they actually get their positive test, and because that's not instantaneous. And so, certain people slip through the net because of that issue. And also the result of contact tracing and testing is that people quarantine at home, where they still might infect people. If you could quarantine people on the moon, it would be different, but they get quarantined at home, where they still might infect people. And that's particularly relevant to care homes, I think. So then we also looked at, so those are sort of interventions that impact individuals. We'd also looked at interventions on locations. So we found that the full lockdown is very effective at reducing cases and deaths. An 11 p.m. to 6 a.m. curfew is a little bit less effective. It's actually, it doesn't make a huge difference at all. And then we also looked at the targeted lockdown, where the rule is that if you live in a household with at least one person over the age of 65, then you're subject to lockdown, but everybody else can do what they like. And we found that had quite a substantial impact on deaths, while still allowing large numbers of people to go to work. So that was a hypothetical intervention that I don't think anyone actually tried. So then finally, we looked at vaccination. So the top two slides concern a scenario where we're sort of vaccinating against a future outbreak. So this is to do with herd immunity. So what we have here is the situation where a certain percentage of the population are assumed to be immune from the very outset. And what we found is that even with only 30% of people immune against the virus selected at random, we were getting quite substantial reductions in cases and deaths. And that sort of connects to the slide that I showed you about the comparison with the ODE model. In the sense that in the context of the ODE model, herd immunity threshold is 1 - 1 over R0, which if R0 is 2.5, that's like 60%. But because of the heterogeneities that really exist that we tried to capture with the model, we see substantial levels of protection at much lower levels than that. So for example, 30%. And then we also looked at the situation where you're vaccinating 3 weeks into the epidemic. And we found that, so we looked at daily dose capacity, efficacy, and hesitancy, vaccine hesitancy. And essentially we found that hesitancy was sort of somehow the biggest threat to a successful campaign. And obviously we went into a bit more detail on that in the paper. So we've got a little website. This is the code, and then this is the preprint. So yeah, that's everything I wanted to show today. So thank you for listening.
Super, thank you, James.